some important points that the session will lively streaming on YouTube, and also you can find it, the recorded version of the session onto the website, and may follow this session. Also, you can ask your questions directly in chat section, so we can, in the panel discussion, we can share it with their lecturers. For attendance certification, you should go to the website and register onto the website. Your attendance will be checked through Zoom participants list. So please use your actual name as a Zoom display name. After the end of the Congress, you can go to the website and download your certification. Also, for Iranian participants, we have CME score. For getting the CME score, you can register in IRCME website and attend the session quiz and get your score. We are formally starting the session with sharing the session clip. Enjoy the session. Thanks for watching. I want to kindly introduce dear Dr. Behdad Qarib, the dear facilitator of the session, who helped us arranging this session in this wonderful Congress. Dear Dr. Qarib, we are with you. Dear doctor, we don't have your voice still. Just no, we are waiting. No problem.
Can you hear me now?
No, dear professor. So sorry for this interruption. We are having the Dr. Ghaib in some minutes.
Mhm. Hi, everyone. I think you can hear me now. Today, we are going to talk about children's health in humanitarian crisis by Médecins Sans Frontières, MSF, or Doctor Without Borders team, as natural disasters happen time to time. And it seems that humans' greed to bloodshed and war has not been diminished over time. We thought that it was very important to have a session about children's health in humanitarian crisis. So we have invited the team of MSF experts for these lectures on children's health in disasters. MSF, or Doctors Without Borders, is an international independent non-governmental medical humanitarian organization that provides medical assistance to people affected by conflicts, epidemics, disasters, or to those who are excluded from health care. Their team are made up tens of thousands of health professionals, logistics, and administrative team. It was founded in 1971 in Paris by a group of journalists and doctors, and they have been working in Iran for about 30 years, and they are still working here. Our first lecturer is Thomas Balivet. He is the head of mission of MSF in Iran. He has been working with Doctors Without Borders for about 22 years, and he has worked in Central Asia, Palestine, Yemen, Jordan, Syria, Pakistan, and Afghanistan. And as I mentioned, he is the head of mission of MSF France in Iran. Thank you very much for your participation. And we are going to start the lectures with Thomas Balive. Thank you.
Good morning, dear colleagues. Thank you for inviting for this International Congress on Pediatrics. I will do a short presentation on the activities of Doctors Without Borders in general. So MSF was created in the 1971 by a group of doctors and journalists who are mainly initially worked for the International Committee of the Red Cross. Our charter is based mainly on as a priority assistance to population in distress, with the principle of neutrality, independence, and impartiality. And a lot of our action is based on volunteers activity. So we operate in different kind of setup for natural disaster, healthcare needs, conflicts, epidemics, and pandemics. Concerning conflicts, it represents 30% of our activity, mainly related to areas of instability, conflict zone, either international conflict or non-international conflicts. It has been one of the important aspects of our work. Of course, linked to it, of course, there is a lot of activities related to surgery, war surgery, but we do also different kinds of other surgeries related we go from C-section to plastic surgery. And for example, in Malawi in 2020, we work also on cervical surgery related to cervical cancer. Concerning disasters, of course, it's also one of the important activity of our work. We are able to answer rapidly to disaster, especially in zones when we are already located on the ground, where we have already activities, like in Haiti, for example, in 2010 and 2016 for the earthquakes, but also, as you can see on the picture, in Lebanon when there was the explosion in Beirut. Concerning epidemics, so MSF was one of the first actors to treat massively patients on HIV and AIDS, and with a lot of aspect of lobby to bring down the prices of drugs. In 2014 and 15, we worked on Ebola virus outbreak in West Africa, 2018 and 19 also, Ebola epidemics. And as you know, also in 2020, the pandemic of COVID, where MSF was active in more than 70 countries. Related to our field activities, we regularly have also activities related to cholera, measles, tuberculosis, sleeping sickness, and Kala-Azar. One other activity is massive vaccination campaigns, like this one in Central Africa in 2020. It's one of the big work on prevention of diseases done by MSF. Nutrition also is a big activity related to our work, because as you know, according to UNICEF, 1 in 4 children under 5 suffer from malnutrition. So, and the consequences are particularly severe for children less than 2 years of age. Now we have new mixes, which is kind of used on ambulatory. It's kind of paste made of different nutritional elements, which are distributed to the families, and the cure rate of malnutrition can go up to 90% in risk area. So it's quite successful, and we lobby to work together with the WFP to include this in regular distribution projects. Research is one of also of our active field, because we have to try, based on the research that we do on the ground, on the access to certain diseases, we are able to collect data and to produce some articles in the research papers, and also influence the evolution of creation of new drugs, which is, as you know, particularly important for countries with low income. Infectious disease, very important also, like chemoprevention of malaria, tuberculosis, and these, which are quite big killers worldwide, unfortunately, and a lot of operational research is going on, and a lot of treatment also is going on MSF fields. Hospital support. MSF is one of the big organizations who is able to deploy rapidly some hospital structures with secondary, even up to sometimes tertiary healthcare, where we can have surgery, we can have ICUs, we can have a newborn unit for premature children also. This picture is of one of our hospitals in Cox's Bazar refugee camp in Bangladesh. Of course, all these kind of activities go together with preventing diseases, especially waterborne diseases. So that's why we have a big sector related to what we call WATSAN, or water and sanitation, to provide good quality water and to treat the waste, also to avoid epidemics. As I told you at the beginning of the presentation, MSF was also created not only by doctors, but with also journalists. So sometimes MSF bears witness if MSF is facing some humanitarian crisis or massive violation of human rights, especially related to conflicts and to displacements of population, indiscriminate bombing on population, and something like this. So this is one of the important activity of MSF in general. All these activities, medical, etc., cannot be deployed without a big logistics support also. So we have several what we call logistical bases or hubs, where our purchases bases are done also for drugs, for equipment, and all these are stored and put into kits that can be rapidly deployed and sent to the more than 80 countries where we work now around the world. So it's also an important aspect of our activity. MSF is not only a MSF, it has also a broad network of several entities which are related mainly to access for essential drugs for countries with low income. We support also research and initiative related to drug for neglected diseases. We have Epicentre, which is also an epidemiological center for research and study on different aspects of public health. And what we call the CRASH is a kind of humanitarian think tank about the practices in humanitarian law and humanitarian action and all what is related to the action of on the field that can be done by MSF in general. Some figures about our activities. As you see, a lot of still malaria cases are treated by MSF related to infectious disease, HIV treatment, surgical activities, a lot of surgical activity, especially in conflict-related environment. And also obstetric is kind of an important aspect of our work with we working on issues like fistula, for example. And voilà, so you have an overview of all the actions of MSF in the world with these different figures here. Concerning project locations, so as you see, MSF is mainly related to countries with low income that are affected by epidemics or conflicts or all kind of difficult social and public health situations. So most of our activities are currently now in Africa, 55% of our projects, but also in Middle East due to, unfortunately, the many conflicts that exist in this part of the world. And Asia Pacific, America, even in Europe, we have quite some activities related for access to health for migrants, for people who fall outside of the public health system. Context of intervention, as I told you initially, 31% of our activities are related to armed conflict, but in fact, the majority is related to stable environments. So it's public health, like, as I said, related to epidemics, long-term treatment like tuberculosis, HIV, etc., which this context represents 46% of our activities. Our financial resources are coming 97% from private donors, a little bit, very little bit from institutional donors, but vast majority is 97%. So it gives us an independence where nobody is telling MSF where to intervene. No, we are not linked to any kind of funding from any government, which gives us a rapidity and independence in our activity. The expenses we have, it's for the year 2020, has reached $1.6 billion in MSF all over the world for our, what we call our social mission. Human resources, a lot of people are working in HQs because we have to have strong HQs with technical resources, logistical resources, legal aspect, logistics, human resources, etc. So we have quite strong headquarters, but majority of the work is done actually on the different projects with 37,000 national colleagues, be it doctors or nurses or all kind of professions, and supported by technical support and management from what we call expatriates, which are foreigners who go to do the activities in the different countries. Finally, the different types of jobs that are existing in MSF. You have, of course, medical and paramedical, like doctors, nurses, surgeons, anesthetists, but we have also psychologists, psychiatrists, midwives, social workers, community health workers. So all these are part of the package related to the medical intervention. To support this, we have managers, basically logisticians, who set up all what is related to the technical aspect to the medical support, and to manage the budgets and the human resources. We have, of course, administration and finance personnel also. MSF has become now a big system which is funded on 5 operational centers, which are at the core of this system. We call them OCs, and there are one in France, one in Belgium, one in Switzerland, one in Greece, and one in Spain. And basically, these are the operational centers that are able to carry activities. But we have a big network all over the world with different offices that provide human resources, communication, financial resources, of course, and all this is organized with the support of an international body called MSF International, which is kind of advisory body. But the core of the activities is mainly with the 5 operational centers that I mentioned you. Voila, so this is some basically about MSF presentation. Where can you reach us? You can reach us on our website on msf.fr or msf.org, and with the different media on social media, and always ready to listen, and you can have access to the different fields and the information about all our activities on this project. This is it for me. Thank you so much, and I hope that you enjoyed this presentation. Thank you very much, and I wish you a good Congress.
Thank you very much. Thomas Balive was the head of Médecins Sans Frontières in Iran. Our second lecturer is Melissa Hozjan. She is a Canadian-trained registered nurse living in Australia for the past 15 years. She has a master's in public health, tropical medicine, and in intercultural and international communication, and postgraduate certificates in infection control and global health and quality improvement. Melissa has worked as a nurse in over 20 countries, and for the past 10 years with Médecins Sans Frontières as medical team leader, and since 2018 as pediatric nursing advisor with the Paris Medical Department. Thank you very much. Now we have the lecture of Melissa Hozjan.
Hello everyone, and welcome to today's session, Children's Health in Humanitarian Crises. I'm Melissa, Pediatric Nursing Advisor with Médecins Sans Frontières. On behalf of my colleagues, I would like to thank the organizers for inviting us, and to all of those listening in today. We will begin with a presentation introducing MSF and humanitarian crisis and the factors which impact on a response. It will be followed by my colleagues Nicola Morton and Greg Kane, who will discuss the implications this presents for children. Created in 1971, Médecins Sans Frontières is an international medical humanitarian organization. You may have heard us referred to as Doctors Without Borders, or simply as MSF. We provide healthcare in complex humanitarian settings to everyone who needs, irrespective of race, religion, creed, or political convictions. Our actions are guided by medical ethics and the principles of impartiality, independence, and neutrality. We do not take sides or ally with any party in a conflict, and carry out humanitarian action without discrimination of any kind. This is particularly important working in crises where an urgent response is often needed. Our independence allows us the means to act when, where, and how we see we can have the most impact. More than 95% of our funding comes from private donors, with 85% of the donations directly supporting our social mission. Our activity is delivered where it is needed most, in emergencies such as armed conflicts, epidemics, famines, and natural disasters. People who are displaced and those with pre-existing needs still need care, and the risk of disease outbreaks are heightened. Restoring basic health services are vital to avoid illness and death, particularly for women, children, and newborns, as will be discussed more in the following sessions. We have projects that focus on maternal child health, non-communicable diseases, infectious diseases, surgical products, and mental health programs, to name a few. These may be delivered in an inpatient setting or as an outpatient at a mobile clinic, at home, or in search and rescue boats, such as in the Mediterranean. We also work to raise awareness for global populations and on behalf of the people that we assist. In the 50 years since being founded, MSF now has over 450 projects in over 70 countries around the world. This map indicates countries where we work, but in fact it was pre-COVID. It's a little bit outdated. We have since provided support in many countries where we had previously not worked, like the United States and in several European countries. Our teams are made up of tens of thousands of health professionals, logistics, and administrative staff, most of whom are hired locally. International staff represent just 8% of our total global workforce. I'm going to discuss briefly some of the many factors that impact a humanitarian response, some which may be a direct result of the crisis, and others which are compounded by pre-existing factors. These include access, supply, context, structures, collaboration, human resources, training, and emergency preparedness. Access to healthcare can be challenging, particularly in low-resource settings where facilities may be few, under-resourced, or understaffed. Patients may need to travel long distances to receive care. This can be compounded in a crisis where roads are blocked as a result of a conflict and the journey might be unsafe, or due to environmental factors like flooding. As a result, patients may present late or in poor condition after having to travel so far. Referrals to higher levels of care is challenging or might even be impossible, or these facilities may not exist. These images are from a project in South Sudan. On the left is a Google image of the primary healthcare center when we arrived, and on the right, a photo I took as I left the project 3 months later. Our objective was to rehabilitate the facility and support the population by providing supplies, training for existing staff, and referral options. You can see the remoteness of the facility, which also became almost an island in the wet season. This made it really difficult to access and made referrals to our hospital facilities several hours away very difficult. This video was taken on that route. You can imagine the logistics involved in transporting supplies to our center and also referring patients from the primary healthcare center to the hospital, which on a good day was a couple of hours, but could certainly take much, much longer in conditions like this. Following a crisis, there is a high demand for supplies. These may rupture quickly or be destroyed, necessitating rapid on-the-spot assessment and problem solving to ensure the minimal impact on patient safety and quality of care. Restoring supply can be challenging if access is complicated, if supply lines are cut, or if borders are closed. Importation restrictions can impact on access to some supplies, morphine as an example, or even hand sanitizer with high alcohol content. This impacts not only on healthcare and medications and supplies, but essential equipment like generators and fuel. At the onset of COVID-19, globally there was a shortage of the essentials of personal protective equipment, PPE, and in many contexts in oxygen. The bulk of our supply comes from European warehouses, making it even more difficult as international travel was limited at that time. The image on the left is of an MSF European warehouse, and on the right, an MSF supply convoy in Yemen, filled with medical supplies and crossing the front line into a besieged area in Taiz province in Yemen, taken in 2015. You can see the logo on the top of the truck, which was used to identify us from above. hospitals where the most vulnerable, the sick, and the injured gather. In conflicts, hospitals have a high number of patients coming at the same time, overflowing the structures. Limited staff and 24-hour curfews result in longer working hours and fear of being exposed to the risk of violence or attacks. And this is not only for patients and for staff, but also about the safety of their loved ones who might be at home. Attacks against medical facilities and health workers, whether deliberate or indiscriminate, are part of generalized violence and atrocities committed against civilians in armed conflict. As a result of these kind of incidents, on several occasions, MSF has had to temporarily suspend medical activities, including providing life-saving care, supervising health center staff, supplying drugs, and transporting patients. The image on the left is in an emergency room in Aden in Yemen, one of our largest trauma centers. And to the right in Syria, following a missile crisis or missile strike, which resulted in 80 being treated in the hospital. Both of these images were taken in 2015. Context can also impact on other factors. Electricity supply may be infrequent or disrupted, and alternatives such as generators or solar panels might not be available or were destroyed. Electricity is needed for the running of oxygen concentrators, suction pumps, lighting, sterilization, and equipment. The basics of clean water may not be available due to contaminated water supply systems or the environment and the terrain. Sufficient latrines are required to maintain sanitation and waste management and to minimize the risk of waterborne diseases. This impacts on the provision of healthcare, for example, basic hand hygiene, assisting patients with activities of daily living and their personal hygiene, and thus reducing risk of infections. The flushing of nasogastric tubes is a very simple example. And then the wider issues of cleaning and disinfection of equipment, cooking supplies, and feeding of patients and laundry services. These are images I took in Bangladesh in 2017 in response to the large exodus of Rohingya fleeing violence in Myanmar. They demonstrate these challenges of water and sanitation. The image on the left was taken on my first day in the refugee camp when there were hundreds of new arrivals every day. This was about a 2-hour walk into the camp. There were no roads. You can get an idea of the terrain, very hilly and covered in trees. The image on the right was taken in a similar location a few weeks later. A road had been built, which made access slightly easier, but where are the trees? As they were cleared for housing or for fuel and to make space to settle, the hills were becoming increasingly unstable. In addition, when it rained, all of the runoff went into the valleys between. This included sanitary waste, and Hosjan was certainly the emergency priority here, ensuring that there was sufficient water, supply of water, and that it was accessible and clean, in addition to latrines. Providing care might take place in partially collapsed, ill-equipped facilities or buildings, like these health facilities seen here in Yemen, that were damaged next to a school that had been destroyed. Tented field hospitals can be constructed quickly and nearly anywhere, like this one after the earthquake in Nepal in 2016, or this post-operative tent in Banguy's Community Hospital in Central African Republic in 2014. However, they are not without challenges. They are often very hot or very cold. They lack spacing for patient privacy and have the additional challenge of maintaining good quality infection prevention and control standards. As discussed, there are many needs and often many people and organizations wanting to help. Collaboration is crucial following any humanitarian crisis, ensuring that there is coordination between all actors and all needs are identified and being met. This includes not only the provision of healthcare, but also infrastructure, water and sanitation, and ensuring that there is equitable access for all those who need. For example, in context of mass population movement, where internally displaced and refugees are resettling into new communities, the host population must also be considered into the needs and the impact it has on them. Healthcare workers are often a part of the communities they serve and may have to care for their own family members, friends, or acquaintances, or be called upon to care for perpetrators of the violence or members of hostile forces. In disease outbreaks, there may be the additional fear, stigma, and perhaps community misunderstanding of taking home the disease of those they are caring for. This is something we're all even more aware of now with COVID-19, and certainly during the outbreaks of Ebola, as the one in 2014 in West Africa. As needs increase during a crisis, there's a greater need for qualified healthcare workers to respond. In many countries where MSF works and where the needs are highest, there are limitations to the availability of doctors, nurses, and midwives. You can see the countries in red in these maps is very similar to the map I showed earlier, which depicted the countries where MSF works. In this map, it indicates where the proportion of healthcare workers are limited in red, with the one on the right being physicians, where there's less than 5 per 10,000 population, and nurses and midwives less than 10 per 10,000 population. There are many contributing factors, such as weakened healthcare systems, lack of educational facility, access to education, and interruption to education for reasons like conflict and population movement. This lack of skilled health professionals, and in many cases, the loss of skilled health professionals, creates a vacuum in expertise and an increased urgency to support existing professionals with the needed skills. Training and building capacity for healthcare workers is crucial in order to improve the quality of the healthcare and to strengthen the local health systems. In an emergency, rapid recruitment must be balanced with training while ensuring that an already weakened healthcare system is not impacted and that support is based on the needs. For example, unfamiliar and new disease outbreaks such as Ebola and COVID-19 require additional training and adaptations in infection prevention and control. The nature of war injuries and the weapons used in recent warfare cause massive tissue destruction, increasing the likelihood of infection and management of multi-drug resistant organisms. Facilities must be prepared to receive and manage a mass influx of patients with a well-rehearsed mass casualty plan in place, as everyone has an important role to play. In addition to training, what else can we do to prevent, mitigate, and prepare for a crisis? Our response varies from place to place according to the impact, the population, and how quickly we can mobilize. We may already be working nearby and monitoring for changes such as seasonal peaks of malaria, endemic disease outbreaks, a rise in malnutrition presentations, or changing security contexts while liaising with authorities and other organizations also responding in country. MSF has developed pre-packaged disaster kits, including a complete surgical theater, an obstetrics kit, and an inflatable hospital with communications material, power supplies, water processing facilities, and nutritional supplements. These kits are stored in warehouses across Europe, East Africa, Central America, and East Asia, and are already custom cleared and ready to be loaded and flown into crisis areas as quickly as possible. MSF's prepackaged kits are now used as models for emergency relief organizations worldwide. There are many challenges in humanitarian settings with direct and indirect effects impacting on the most vulnerable. I will now hand over to my colleagues for their presentations on pediatrics in humanitarian crises. Thank you.
Hi, I'm Nicola Morton and I'm Pediatrician and Pediatric Advisor for MSF Operational Centre Paris.
Thanks a lot to dear Dr. Hosjan. We are going to be with Dr. Ghaib again for introducing the third lecturer.
Thank you very much. Our third lecturer is Dr. Nicola Morton. She is an Australian pediatrician who first joined MSF in 2014 and worked in Pakistan, Afghanistan, Kenya, Yemen in the fields of pediatrics, newborn care, and nutrition. Nicola joined the medical department of Operational Center Paris in 2017 as the pediatric advisor based in Sydney and provides technical support both remotely and in the field in projects in countries including Afghanistan, Pakistan, Yemen, Bangladesh, Lebanon, Liberia, and South Sudan. She also continues to work as a consultant pediatrician in the Sydney Children's Hospital Network and the clinical lead for child refugee health. She is going to talk for us. Dr. Nicola Morton, thank you.
Hi, I'm Nicola Morton and I'm Pediatrician and Pediatric Advisor for MSF Operational Center Paris. Following on from Melissa's talk, I'm going to focus on the specifics of pediatric care in a humanitarian crisis. Because of their inherent vulnerability, children are disproportionately affected by war, disaster, and economic crises. So how do humanitarian crises affect child health? These are the sorts of things we see in the media, but these are just the tip of the iceberg. The reality is much worse. Humanitarian crises, including both conflicts and natural disasters, are responsible for significant child mortality. We know that 1.6 billion children live in conflict-affected areas. And we know that because of this, there are a rising number of people displaced from their homes, reaching 82.4 million people, and half of these are children. Over a third of all child deaths occur in countries either affected by conflict or that have a sizable refugee population. If we look at under 5 mortality rate according to context, it demonstrates this. We start with high-income countries, which have less than 0.5 per 10,000 per day. But then if we move to low-income countries, that doubles to 1 per 10,000 per day. But if we move into emergency context, we can see that that rises exponentially, reaching more than 5 per 10,000 per day in context with humanitarian catastrophe. So severe famine, major epidemics, natural disasters, and conflicts. This is a map representation of the distribution of under 5 mortality throughout the world, and you can see the concentrations in certain regions. If we break it down by country, these are the 20 countries with the highest under 5 mortality, and the ones I've highlighted are the ones where there is active conflict. You can see they make up a significant proportion of this 20. And some of the ones that aren't highlighted have had very recent conflicts or ongoing instability. But what are they dying from? These are the top causes of mortality in children under 5 years. The leading cause of death in children under 5 years of age are neonatal complications. That includes prematurity, birth asphyxia and birth trauma, and neonatal sepsis. These are followed by respiratory tract infections, diarrheal diseases, and malaria, and then lastly trauma. And in fact, trauma is the leading cause of mortality in children between 5 and 14 years. All of these 5 can be prevented or treated with access to affordable interventions in health and sanitation. Let's firstly look at the direct effects. More than 1.5 million children are estimated to have died as a direct result of violence in just over a decade. That's 25 children killed or injured every day, and it is increasing. If you look at the more recent conflicts compared to the historical ones, you can see the proportion of civilians to military deaths is increasing, with a 10-fold increase compared with World War I and the war in Iraq. Areas of conflict, dangerous place for children. in particular in places like Syria, Somalia, Afghanistan, Yemen, and Nigeria. Many children suffer death and injury due to conflict. For example, in Afghanistan, it was reported that 9 children are killed or injured every day. Not only are children injured or killed when they are in the wrong place at the wrong time, but there are increasing incidents of direct attacks against civilians, including children. And there is clear evidence that this is increasing. An example such as the school bombing in Afghanistan or the attack on the MSF maternity facility in Dashtabachi in 2020. There are also many deaths and injuries due to landmines and other explosive devices. And we know that these disproportionately affect children, both accidentally but also at times intentionally, with reports of unexploded devices intentionally hidden in children's toys and left in houses for them to find. And we know that these can occur months, years following the conflict, with many unexploded devices left behind. And just as deplorable is when children are used as weapons of war. It is estimated that there are more than 300,000 child soldiers worldwide. An example was in Uganda, where 90% of the soldiers in the Lord's Resistance Army consisted of children, with children as young as 4 years of age being abducted and forced to be involved in military action. And children have also been used as suicide bombers in many countries, which is just unthinkable. And while these direct effects are confronting, some of the indirect effects are just as confronting and just as deadly for children. To highlight this, I want to start with a story of a child that I met when I was in the field a couple of years ago. This was in Yemen. Yemen is a country in crisis. It has been ravaged by war since 2015, and it is the civilians that suffer the most. But I want to take you to a remote village in the province of Amran, in the north of Yemen, to this house, where Mariam is in labour with her 3rd child. Like many Yemeni women, Mariam is labouring at home. There is no healthcare provider to help her, and she's supported by only her mother-in-law. Mariam is in labour for many hours, too many that she loses count. At times she is very scared as this seems too long and she fears for her baby. But after what seems like many hours of pushing, finally the baby is born. When she hears the cries of her baby, she is overjoyed, a little girl, and she names her Aisha. But soon her relief is again replaced by worry. She begins to be concerned about her baby's condition. She's very unsettled and will not stop crying. Nothing they do will settle her, and she is refusing to feed. She feels hot to touch, like her skin is on fire. Mariam is very worried for her baby, as is her mother-in-law. As Mariam is soon after delivery and not well herself, her mother-in-law, Aisha's grandmother, is the one who must take her to get help. But she knows she must set out on foot. They are poor. The family survive by tending their 2 cows, so with rising prices they have no way to afford a taxi. So at 4 a.m, the day after Aisha was born, Aisha's grandmother sets out on foot to get medical care for her sick granddaughter. She walks to the nearby health centre in their village, and there she sees the clinic staff. But they tell her they cannot treat Aisha. They do not have any drugs or equipment to treat the small baby. So she keeps walking. She then arrives at the local hospital in the nearby town. It has been completely destroyed, so no help to be found there. So she keeps walking. She walks for over 6 hours before she reaches the MSF hospital in Hamia. She arrives exhausted, with blisters on her feet, but finally relieved to find the hospital that would be able to treat her granddaughter. Aisha was admitted to the neonatal unit and commenced on treatment for umbilitis, infection of the umbilical cord, which is life-threatening if not treated. She was treated with intravenous antibiotics and fluids, and slowly she began to improve. Her grandmother was able to see the improvement day by day, relieved that she was now settled and able to feed. I met Aisha and her grandmother on the day they were to be discharged, and her grandmother couldn't hide her happiness. She even took her socks off to show me the blisters that hadn't yet healed on her feet. She told me that she would walk the 6 hours again, as now her granddaughter has a chance to live. This is far too common a story in Yemen, but Aisha is one of the lucky ones. With great efforts by her grandmother, she was able to get the medical help she needed in time, but many are not. The situation for many people living in humanitarian crises is similar, and we see many preventable deaths. Many of these can be attributed to the direct and indirect consequences of these crises. As in Aisha's story, the destruction of health infrastructure is a huge issue. We have seen in places like Yemen and Syria the almost systematic destruction of health facilities. This is often further compounded by the lack of health professionals in these vulnerable areas, both from pre-existing deficiencies and then further depleted by the conflict or crisis. This leads to reduced access to healthcare at all levels, but we see this particularly in maternity and neonatal care, which is often deprioritised. But there are also significant reduction in primary and preventative healthcare and just health facilities in local areas for people to be able to reach early medical care. This is further compounded by the environmental conditions, by lack of housing, overcrowding in camps, and the impact of poor water and sanitations, making the population even more vulnerable. And so we see an increased incidence of common diseases, particularly conditions like gastroenteritis and pneumonia. We also see increased malaria burden as there's often interruption to preventative measures such as bed net distribution, seasonal chemoprophylaxis, or test and treat interventions. And we particularly worry about the increase in infectious conditions, particularly something like measles. And to add to this, there is often a disruption in vaccination programs and EPI, so we see outbreaks of infectious diseases such as measles and resurgence of other vaccine-preventable diseases. This map, while it is a little bit outdated, is still representative of things today, that conflicts and outbreaks often go hand in hand. You can see on this map the multiple outbreak events represented by the coloured shapes, and shaded in yellow are the countries affected by conflict during this period. This is exactly what happened in Yemen, with devastating consequences. As you know, the conflict began in 2015, and with ongoing conflict and significant destruction of health infrastructure, resulting in the displacement of over 2 million people. We first saw an outbreak in 2016 with cholera. There was a further cholera resurgence in April of 2017, closely followed by a diphtheria outbreak in 2017, a disease that most health professionals had never seen before until this resurgence. And then in 2018, a measles outbreak. And similarly, we are just now seeing a measles outbreak in one of our programs in Afghanistan. Or similarly, in Bangladesh, there was both a diphtheria and chickenpox outbreak, as well as measles outbreaks in the Rohingya population. And we can't forget malnutrition, which of course disproportionately affects children. The economical impacts in particular have a huge impact on food insecurity, and scenes like this middle picture are not uncommon in large humanitarian crises with such overwhelming need. We all know the impacts of malnutrition on mortality, especially the interplay with infections. But malnutrition really highlights the compounding of many factors in these sorts of crises. If we look at the determinants of household nutritional status, you will see the many facets that a humanitarian crisis can impact, leading to a worsening malnutrition situation. Firstly, food availability and access. The status of crop production and health of livestock, which can be impacted by people not being able to tend to their crops and livestock anymore, either because they're away fighting the conflict, or perhaps it's not safe to do so. Are the markets stocked and is a range of food available? This is also impacted by multiple things, but in particular closed borders or blocked trade routes. And most importantly, can the families obtain the food, even if it is present, i.e. can they afford it? And recently we've seen the impacts of formula milk availability having a huge impact on the incidence of under 6-month malnutrition. And of course, what health services are available? And are there nutritional programs for vulnerable people? Then the environmental factors. Do the security conditions allow people to go to the market? Are the roads physically passable? Is there a public transport system that can get them there? Is there safe drinking water available and in adequate amounts? And then care and capacity. What is happening in the household? Are the men of the household present, or are they away fighting the conflict? Is there employment? Are the women left on their own to meet their children's needs? Are they orphans or unaccompanied minors? All these factors can contribute to the nutritional status of a household. And all of these factors can be negatively impacted by a humanitarian crisis. And this is something that needs to be monitored closely in humanitarian crises, and why population rates of acute malnutrition should be assessed to be able to intervene before it reaches emergency or catastrophic levels. And a worsening malnutrition crisis in an already fractured health system can very quickly overwhelm the health services. And that is why a response for malnutrition is so key, and why most of our responses to humanitarian crisis will involve a malnutrition intervention. But it's not just about surviving. What is it like for a child living in a humanitarian crisis? Is it a childhood? Do they get to grow and develop as a child should? We know that they have disrupted education. There are estimated to be 27 million children who are out of school worldwide, with over 2 million of those in Yemen alone. Many schools have been destroyed, and for children and teachers, it's just not safe to go to school. For example, in eastern Ukraine, where there are nearly 500,000 children affected by the conflict, there have been 36 attacks on schools in just 1 year alone, including one school that was attacked 15 times. We know that these children have likely experienced significant trauma, witnessing things that no one should see, let alone a child. More than 3 million children are living in an area where violence has been raging for 18 years or more, so it's all they have known. Many have lost parents and family, with an estimated 153 million children worldwide who are orphaned. And many will have been exposed to abuse and neglect. And this is a very neglected area in our humanitarian response. And I mean both we as MSF, as well as we as the broader community. So what are the longer-term consequences? What are the implications for children who aren't allowed a childhood? What are the long-term effects of such trauma at a young age? The implications for their growth, development, and mental health are immeasurable. Our next speaker will focus more on these aspects and how our approach must involve mental health support. But what can we do as clinicians delivering this medical care? First, it is ensuring that we deliver trauma-informed care, that we don't further traumatize these already traumatized children. But also, I think we need to think of ourselves not only as pediatric clinicians, but pediatric advocates. And I think our approach needs to be broader than just on the health needs of children, but the broader needs for children. And a good way to approach this is in a child's rights-based approach, and we can divide it into three broad categories. The right to promotion, the basic rights to life, survival, and the development of one's full potential. The right to protection, so keeping children safe from harm. And the right of participation, allowing children to have an active voice. In 1989, there was the UN Convention on the Rights of the Child, which established global standards to ensure the protection, survival, and the development of all children without discrimination. It is the most widely and rapidly ratified human rights treaty in history, with 196 countries ratifying this. The notable exceptions were Somalia, South Sudan, and the United States. I will not go through all these articles, but highlight a few that are crucial when we think about issues for children in humanitarian crises. Protection from discrimination. Best interests of the child as the primary consideration. Parents responsible for ensuring a child's rights are protected. The right to survival and development. The right of the child who is separated from one or both parents. The right of the child to express their view. Freedom of expression, including seeking, receiving, and imparting information. Protection of privacy. Access to information from mass media. Assistance to parents with child rearing responsibilities. Protection from physical and mental violence, abuse, or neglect. Special protection for children deprived of their families. Protection of children seeking refugee status. Rights of disabled children to special care. Rights to health and access to healthcare. Right to an adequate standard of living. Right to an education. Right to their own culture and religion. Participation in leisure and play. And protection from sexual exploitation. When you look at the state of the world, trying to make sure these children's rights are ensured is certainly overwhelming. But the first place to start is the environment that we have direct control over, our hospital environment and other clinical spaces. If you look at these critically, it can radically change your approach to the provision of healthcare for children. There are many things that we could do in our hospital environments, and these are just a few that should be implemented in all our programs. Creating a child-friendly hospital environment, ensuring a safe hospital environment, listening to the children, providing support for the family or carer, and providing psychosocial and mental health support. And these are the take-home messages from today. That children are the most vulnerable in humanitarian crises, and healthcare for children must be prioritised. Keep children safe and allow and support children to grow and develop. Thank you, and apologies I can't be there live for this webinar to answer any of your questions.
Thanks a lot. Our last lecturer is Dr. Gregory Kane. He is a psychiatrist and health service strategist working with general community and at-risk populations internationally. He worked in remote Aboriginal and Torres Strait Island communities in Australia, and has also worked with vulnerable communities in urban setting and homeless people. He has also been working with MSF in Iraq, Palestine, Yemen, Syria, and Jordan. His specific interests include global health, focusing on the health of young people and mothers, as well as health of refugees, indigenous, and other vulnerable people. He has an interest in healthcare system development and management in humanitarian and crisis and low resource settings. He will talk about emotional problems of children in humanitarian crisis.
Good evening. Thank you to Melissa and to Bedad for the introduction. As they said, my name is Gregory Kane. I'm a psychiatrist and the mental health advisor for Médecins Sans Frontières. I'm going to talk to you today, as Melissa said, about child mental health in humanitarian crises, about MSF's experience of children's mental health and mental health care in humanitarian settings. So I'm going to talk about 5 topics today. First of all, understanding common mental health presentations in acute crises. Then I'm going to discuss the spectrum of normal through to abnormal responses and what that means. Moving on to how children exist in systems and why that's so important. And then based on that, how MSF and other humanitarian actors intervene in mental health and psychosocial, with mental health and psychosocial activities. Finally, I'll finish off with some examples of where we work and how we work in MSF, and then share some of the challenges to finish with. So, in humanitarian crises, especially acute ones, it's really not the mental health clinicians that see children and adolescents first. It's usually doctors and nurses in primary health centres. And I just wanted to share with you the experience of one of our paediatricians who was interviewed in an emergency facility early in the Syrian war.
كاختصاص أطفال أكثر مشكلة واجهتني مع الأطفال اللي عم بيجونا سواء من المخيمات أو من ضمن الداخل السوري مشكلة السلس البولي الناجم عن الخوف من قصف الطيارة.
So, as Dr. Alabdeen said, the presentation that she saw the most in emergency settings was children with bedwetting. And we start to think to ourselves, why are children presenting with bedwetting? And what are parents thinking about that bedwetting as well? Next, I want to introduce you to one of the psychiatrists who works with MSF. Her name is Joelle, and she's a psychiatrist who has set up mental health activities for us in various places, including in Iraq, in Mosul, in 2017. And the point of this is to really show you that mental health care for children and for their families really needs to be considered from the start of a humanitarian crisis. Joelle speaking in French here, so look at this up.
C'est une population qui a vécu des choses très difficiles et qui ne se sent pas encore du tout en sécurité, d'autant qu'il continue à y avoir des bombardements, des militaires partout, des tirs partout. Ils vivent dans la peur, ils vivent dans la... J'ai rencontré des enfants qui étaient très en difficulté, qui avaient des troubles du comportement, et les parents, surtout les mères, puisque les pères n'étaient plus là, les mères étaient encore plus en difficulté parce qu'elles-mêmes n'avaient plus la capacité de faire face aux troubles et aux émotions de leurs enfants. Et il y a des mamans qui ne savaient pas faire autrement qu'attacher leurs enfants pour pouvoir les contenir et éviter que leur débordement puisse gêner les voisins ou les autres membres de la famille. Et ces mamans étaient complètement démunies, alors que ce sont au départ de bonnes mères. Elles ne savaient plus comment faire. Donc le travail n'était pas que la prise en charge de l'enfant, mais aussi la prise en charge de la maman et la prise en charge du groupe formé par la maman et par l'enfant, voire par les frères et sœurs.
So as you can see, Joelle's expressing a lot of empathy for these mums coming in with their kids. And in the same way as Dr. Al-Badad has seen children presenting with bedwetting, Joelle's seen parents bringing children in who are behaving badly, to the point where parents are sometimes tying their children up. And we have to kind of put ourselves in the parents' position. They've lost their homes, they've left their cities, and they're living in refugee camps, in tents, very closely packed to people who they might not know, who are staying next to them. And these children are really struggling to deal with the stress of their parents and their own stress and their own loss. And children do what they normally do, which is they act out. They behave in ways that demonstrate their distress. And so in this way, children are very often the canary in the coal mine. They're very often the part of the family that demonstrates stress first, demonstrates mental health stress first, and not necessarily in a classic way of saying I feel sad or I feel worried, but demonstrating that with somatic symptoms, with stomach aches, with headaches, with bedwetting, and with behavioural disturbance, and sometimes school refusal. As I said, children exist within in systems. We can't really consider a child as an independent entity in the mental health sense. Of course, children are a product of their physical development and their cognitive development. They're also a product of the social context that they grow up in. They're a product of the families that they grow up in, and their communities as well, and then also culture and society. And so certain things strengthen and other things weaken that structure. So physical illness for kids can weaken that. Stresses, conflict within families can cause that. And then in this bigger context of humanitarian crises, where community and sometimes society and culture starts to crumble or fall apart, children will also suffer and demonstrate some of these presentations. The other thing to think about is that mental health for all of us, including children and adolescents, exists on a continuum. So we don't think about the presence of illness leading of a child being healthy and then all of a sudden being unhealthy. Usually there's a certain amount of stress that builds up in any of us, and some of us can be more resilient to stress than others too. And it's the same for children. So as you can see on this green continuum here, from the left to the right, most people in early stress are healthy and unaffected. As stress increases, people start experiencing symptoms like difficulty sleeping, sometimes difficult mood, irritation, and worry. And over time, that can lead to mental health conditions and even severe disability. So as you can see, humanitarian emergencies, they disrupt the foundation of a child's good mental health. And in the situations where children lose that foundation, they're unable to move ahead with their healthy development. And that's so important because our functioning as individuals and our functioning as society really depends on these really strong foundations that occur in early childhood. And so these foundations are important. And WHO and other actors have come up with this concept of nurturing care. And it's about these 5 pillars that I'm going to go through now. So the first is the one on the left in green, good health. What does that mean? It's not just good health for the child, but also for the parent. If we can find a way to support physical and mental good health for children and parents, that child can then grow in an effective way and can achieve its developmental milestones and achieve the goals that it needs to grow through adolescence and then into adulthood. What that requires is also safety and security. What does that mean? It's really about a roof over your head. It's about a routine. It's about having enough food and water to be safe and secure. And in humanitarian crises, that is often one of the things that's first lost, like we saw with those kids from Mosul and the children in Syria as well. What else do we need? Well, obviously adequate nutrition. And in humanitarian crises, particularly in chronic ones in certain areas of the world, we can see the incidence of severe acute malnutrition. And that really disrupts a child's development and disrupts a child's mental health. So that's so important to make sure that the children have adequate nutrition. It's a really important foundation. And then on top of that, we need to make sure that there are opportunities for learning, not just for children, and this nurturing care package from WHO talks about young children, but these things are all the same for adolescents as well. So we need to make sure that children, babies, toddlers, children, and adolescents have opportunities, even in humanitarian crises, for these early learning opportunities. And one of the first things we do in mental health in crises, the humanitarian sector, is we try to make sure that education is provided for as well. And then finally, when these things are worked out, we can also support parents to communicate as effectively as possible with their children. Why is that important? It's because brains develop with communication. Children don't just grow up against a screen. Their brains and the neuronal connections connect and build and augment over time, and in response to a communication between the parent and the child, the mother and the child. And so these 5 factors are really important at all stages, and are really important for the good development of that child and for the adolescent and society in general. So thinking about those factors, in an emergency, we then need to respond with layers of intervention that consider all of those things. This is MSF's interpretation of the IASC Standing Committee's intervention pyramid for mental health and psychosocial interventions in humanitarian settings. As you can see on the bottom is that foundation. It's those basic needs and security that we talked about, making sure that people have a roof over their heads, that they feel safe and secure. And then we look at community and family. We think about how we can support people with education, with knowledge, maybe with group interventions, to upskill maybe parents and children in very basic things, in communication, in having routines. These are really important things in crises. So these are the things that are often lost and we need to try to rebuild. And sometimes, often in doing that, the stress and distress that children and families feel can start to be resolved, and people can start to look after themselves a bit more. We then move up to the level of intervention that most of us imagine for mental health actors working in humanitarian crises, which is delivering individual counselling and support for children and maybe parents and children who are suffering symptoms like nightmares, like bedwetting, things that are causing functional problems on the day-to-day and causing a lot of distress for families, and sometimes even for depression as well. Moving up to severe presentations. As awful as it is, we see in some crises, particularly chronic crises where people have lost the level 1, level 2, level 3, that children can become very unwell. This is only a small proportion. It's usually between 2 and 5% of children, whereas that level 2 is more let's say 10 to 15 or 20% of children, but in that top level, that 3, 4, 5%, we can see presentations as severe as suicidality and suicide attempts in children, unfortunately, and also diagnosable mental illness like depression and post-traumatic stress disorder. And these are conditions that are really important for us to have trained mental health professionals ready in the field to be able to care for and support and help those children return to normal. But we need to make sure that we have those other levels there as well. So here are some examples of MSF's actions. What you can see here is a bus and a whole lot of people waiting outside that bus. What I can tell you about that bus is inside is a team of mental health professionals. It's divided up into a couple of cubicles, and these people are waiting to come and see a counsellor or a psychologist or a psychiatrist. This is in one of the camps in Iraq in between 2016 and 2018, in the setting of the huge displacement of people after the ISIS invasion of Mosul. And these people were all living in these big refugee camps and suffering quite a lot as a result. And we were seeing these presentations that Joelle had talked about, that Dr. Al-Badad had talked about, and responding to those with some individual and some group counselling. And this bus is one of those places where we did that to start off with. And this picture on the left is of Omar. He is a psychosocial counsellor now studying psychology, and he's a Syrian refugee himself who was working with us in the Iraq crisis. And you can see some tents behind. MSF does a lot of work in displacement. This little boy is in a displaced people's camp. I'm not sure exactly which country, but he had been displaced from Venezuela in 2018 as a result of the civil unrest in Venezuela. And this is a picture of one of our psychologists who is delivering a group psychosocial intervention. So this is not directly therapeutic. It's an activity that brings kids together. It builds resilience. It'd be some sort of fun activity, maybe creating something, drawing things together, working together and building resilience and rebuilding a sense of identity as well. Because when you move from a place, your own home that you've lost, you're on a journey, a refugee journey or a displaced people journey, it's really important to have some stability and to start regaining a sense of your identity. So we try to have these psychosocial activities that bring kids together, that start to build resilience again. This picture is interesting. This is one of our psychologists working with 2 children in Sierra Leone in the Ebola crisis in 2015. So what happened here was that these 2 little boys, their father had Ebola. He was in the Ebola treatment center, and people who were close contacts of people with Ebola at the time were isolated and had to be kept in MSF quarantine facilities while their blood was tested and until they came back negative. And the psychologist is working with these kids while they're waiting to come out of quarantine, doing some exercises, some drawing, and using that as a way to communicate with children, with these 2 boys while they waited. And their dad got better and they were soon able to go back home. This is a really classic sort of intervention for MSF. What you can see here in this next picture is you can see a child with a nose tube. That's a feeding tube, and this is one of MSF's feeding activities for children with severe acute malnutrition in Niger. You can see here it's a play activity. Why that's so important in malnutrition settings is that one of the things that happens when there's not enough food, when kids get hungry and they get tired, is that they stop interacting with their mums. or their carers, and the carers then stop interacting with them. And it's this negative vicious cycle that we have to try to break. So obviously, the first thing we need to do in severe acute malnutrition is make sure kids have adequate nutrition. It's that one of those foundations we talked about. So that's happening. And then what we're trying to do is rebuild the mother-child bond, rebuild that connection, and we're doing that with play exercises here in this. But we also use baby massage, sometimes bathing, and depending on the age of the child, it might be some education about breastfeeding as well. So that's a really important psychosocial intervention. This is one of our counsellors in Gaza. So MSF's been working in Gaza now for many, many years, since the early 2000s. And this is one of our counsellors who is providing at this time care for children, particularly children with burns. A lot of children in Gaza are living in quite cramped spaces, and it's very easy for them to get burned by cooking oil, by basic fire accidents, and sometimes injuries as a result of bombings too. And again, what she's doing here is using play as a way to interact with the child who's going through dressings. And you can see in the next picture. So one of the things, dressings, particularly for burns, can be very distressing. So we use a lot of psychoeducation for parents, calming activities for kids, and play and other talking approaches, which can really help a kid manage in difficult situations like this. You can see this little boy's also got a burn on his leg, and Miriam, the psychologist, is working with him to support him with that as well. Finally, I want to move on to, as I said, what challenges we face providing mental health care for children and adolescents in humanitarian settings. This is me in that camp in Iraq with Omar. And one of the things I can tell you is that settings can sometimes be difficult. So how do you provide healthcare in a place where tents have been set up, where it might be 45 degrees and there might be no space? And so we have to be creative sometimes with that. And as you saw, we rented a bus in one of the earlier pictures and set up clinics in that bus. Sometimes we do it in tents, and we also do it in places like demountables. So this is Mahmoud doing a consultation with a mother and a child in one of the buses. One of the big challenges, as Nicola and Melissa have pointed out, is the lack of health workers globally, particularly in areas where MSF works in humanitarian crises. So on the right, you can't see because my face is there, but it's the number of mental health workers per 100,000 population in Europe, 62 per 100,000, compared to low income settings on the left, 1.4 per 100,000. In many places we work, there are maybe one or two or even no psychiatrists, and sometimes no psychologists at all, and most mental health care is delivered by nurses, and often people not trained in talking therapy approaches, which are really the most important foundation. And so we need to face that lack of mental health workers wherever we work and think about how are we going to shift the task of counselling to a workforce that previously didn't have that skill, and how are we going to supervise and build that capacity in the people that we hire so we can deliver that talking therapy and sometimes psychiatric care, including medication, to very, very unwell people. This is one of the big challenges that we face. Another thing that we face is a lack of data on child and adolescent mental health. And I read somewhere, you can't manage what you don't measure. And UNICEF, which is the UN agency representing children, has identified a real lack of data on the mental health status of children and adolescents. There are these really big population level studies on mental health in times of peace and during emergencies. And what we see is that, as I said before, in humanitarian emergencies all over the world, no matter where you are, the prevalence of severe mental disorder more than doubles from 2 to 5%. And similarly for mild and moderate disorders, increasing from about 10 up to about 17%. Now that data, those statistics come from huge population level studies in many, many countries. But when you drill down into that data, very, very little of it is based on population level studies on children. And so it's something that we really need to work on in order that we really understand the needs of children and adolescents. And I would say adolescents are particularly vulnerable. We really haven't yet done well enough in considering mental health care for adolescents in humanitarian settings. And if we think about it, probably in all countries, we could do a lot better with adolescents. We kind of leave them a bit. And that's because it's a challenge working with adolescents because of the developmental phase that they're going through. So as well as the routine stresses of their teenage years, during humanitarian emergencies, adolescents also face other challenges, and you can see them here. You can imagine the consequence of an adolescent losing access to school and social environment at a time in their life where they're trying to separate and individuate and become adults or become separate beings from their parents. And to lose those social contacts and those other figures outside of the home is really a negative impact. What we see is families sometimes in different cultures will often think, my adolescent girl is unsafe, I'm going to marry her off to someone. And that leads to sexual violence perpetrated against young girls and terrible outcomes as well. So it has the adverse consequence, the opposite consequence to what we wish. We see adolescents facing increased sexual violence and consensual or coerced sexual activity. And in some countries, there's a really high risk for adolescents, particularly boys, to be forced into recruitment to armed groups. And these are really boys, you know. Adolescents also don't often get access to good health services that really fit what they need. And what we know more and more is that meaningful participation of adolescents into development of their own health services and even delivery of some of that health is the best way to make it acceptable and to help improve healthcare. So we're trying to do that MSF in a couple of places now, and we'd like to see that model expanded as well. And finally, it's really important to have scalable interventions that are evidence-based for children and families. So we want to be able to reproduce what we do, and we want it to be acceptable, as I said. And I just want to give you one final positive example of a book that was produced by the Interagency Standing Committee of the Mental Health and Psychosocial Group. It's an international group of international NGOs and UN agencies who worked together in the direct commencement of COVID to develop this book called My Hero Is You, and you can see that written in Farsi there on the left. This book has been translated into 138 languages. It was developed with artists and with mental health experts and with over 1,700 children along with parents and teachers, with a survey to understand what are the things that kids are worried about, what do they need to know and want to know about COVID, and how can we support them. And as a result, this book was written. It's been printed in the hundreds of thousands of copies, read by millions of people, and it's being used by children, families, teachers, schools, and mental health clinicians all over the world to help work with kids. And there's a book that goes alongside that that's also been translated into many languages that helps parents and other professionals talk with kids, talk with them about COVID, about the stresses related to COVID, and helps them manage the things that they're stressed with. So in summary, you can see that we have a lot of challenges and a lot of things we need to do to support the mental health of children and adolescents. And I'm so glad that we could start talking about this here today together. Thank you very much.
Dear audiences, I was touched by the presentation of our friends, especially that of our friend Gregory, and we are trying to reach him and get him live into this session. So, as you may know, these topics, such mental health of our dear kids during crisis, that is so important. So it is a value that if you can stay with us for a few minutes, so we can reach for Gregory, and I'm sure that there are so many questions that we are willing to ask him. So just let us have a few minutes with you, and if we can have our okay. So just let us believe that these sessions and these discussions about topics related to health in difficult situations may be open new windows, new doors for us as pediatricians or as physicians in general, to help more people, more kids, especially in difficult situations. Dr. Gharib, if there is any points that you can add to us, it will be great.
We are waiting for dear Dr. Gharib. I just want to give a huge thanks to the MSF group and all dear lecturers. The lectures were awesome, and exactly as Dr. Aghay mentioned, we are so touched about that. You know, especially all of us in around the world, we are experiencing COVID pandemia. So it is itself a big crisis. However, we have many different crises all over the world: wars, natural disasters, and many things that the worst affecting our children. So it's better to open a new window and a new era in a way that we look at the managing the disaster. Dear Professor Gharib, I'm passing to you.
Thank you very much. That was great presentations. Actually, in Tehran University of Medical Sciences, and especially in Children's Medical Center, we were concerned about the health care of children in humanitarian crisis. Iran is all of the natural disasters, almost all of them, happens here in Iran, and we are our neighboring countries are very prone to war, and many of them still has humanitarian crisis, and all of the our country neighbors around have had this experience of war and conflicts, and also natural disasters. And Médecins Sans Frontières, Doctors Without Borders, they have acted in all of these natural and man-made disasters. Their base in Iran have been here for almost 30 years ago, has been here for 30 years, and they not only try to assist in humanitarian crisis inside Iran, but also they have worked in neighboring countries from Iran base. So their base in Iran has been a headquarter for assistance in Afghanistan, Iraq, and sometimes in Pakistan and other countries. So we have asked the MSF team to have these lectures here, and they kindly accepted to have these lectures here. We are very grateful to the MSF team and also the MSF team in France, in Australia, and also the MSF team in Iran.
Dear Dr. Ghaib, do you have any opinion or any information about the training and practicing sessions held by MSF?
Yes, actually, MSF is doing training for their team. Before going to a mission, they provide a briefing session to the team that are going to be sent to the field, and also they have also the briefing after finishing the team, after finishing the mission, and even after each of the shaking events happens in the field, there are debriefing sessions. There are some training sessions in headquarters for those who have been working for a long time, and the team is very expert, and they have workshops for those who have been working for a long time for MSF. And they are one of the genuine organizations working for humanity in the world.
Thanks a lot. As I know, the general connection to MSF group is the website of MSF, which all workshops and all team leading programs are announcing there. And also there are lots of connections, I mean, maybe phone numbers, emails, and so on. And especially as dear Dr. Ghaib mentioned, we have a branch of MSF here in Iran. So I'm sure that you can find out the information about Iran MSF there. And also you can join the workshops and so on, and maybe you can be a part of MSF. As the topic is something that's addressing whole world and whole people, I want to ask all audiences and participants if you have any experience about being in a disaster or being in a crisis, or work as a humanitarian physician or nurse or anything else. You can raise your hand so I can open your microphone and you can share your experience with us. Do you yourself, dear Dr. Haib, have you any experience about being in a disastrous or crisis situation, helping as a physician?
I have started with MSF in Afghanistan crisis. And before that, there was a flood at north of Iran in Golestan province. I was there in the flood crisis at north of Iran. And after that, for some years, I worked with MSF and MDM, Médecins du Monde, Doctors of the World. And we have been notified that children, women, and minorities, like immigrants or those who have escaped their mainland, they are the most vulnerable population, and many times they are missed. And we had this mission and this duty to find the vulnerable population. It was at the beginning of an emergency. Normally, we may not have time to care for psychiatric or emotional problems, but later, when the emergency phase settled down a little, the next priority is to think of the emotional and psychiatric and the mental health of the population, especially children, because they are the most vulnerable and they can be easily missed, not only because they are children, because they are very weak, very vulnerable, easily affected by the condition, and they are totally dependent on their parents. Their parents, as Dr. Kane said, themselves are not in a good mental situation to help themselves, and so there should be a setup to think of that and try to bring back children to normal condition as much as possible. And I remember that in BAM earthquake and in Zaran earthquake, the welfare organization in Iran, Behzisti, have started to work for children's welfare. They have they had kindergarten for children. They set up these special facilities, and they did a good job, and they continued that in other disasters afterward. And I hope that no other disasters, man-made or natural, happens again. But in that case, in this session, we learned that we should think of children's health and mental health as a priority. And I wish that all of our pediatricians have this ability to manage these problems in the coming natural or man-made disasters. Thank you very much.
Thanks a lot. Yes, as all of us know, we are in Iran, in Iraq, and I don't know, in Azerbaijan, Pakistan, Afghanistan, in many countries in the Middle East region. Unfortunately, we are under the point of many crises, humanitarian crisis or natural crisis. So it's really important to us, especially as a medical practitioners, as doctors, as nurses, and even any human can point to this crisis, help people, especially children, who, as Dr. Ghaib and Dr. Kane mentioned, are the most vulnerable cases. Dr. Aghai, I'm passing to you.
Yes, Saila, as you just mentioned, and we listened to Dr. Gharib, we are living in a region, especially that is vulnerable to the crisis, both both caused by humans and also by nature. So we are willing to have such sessions in future, and we shall see the pathway through this crisis, and we can go through them holding each other hands. So because of the time that we have missed, and we couldn't get access to our speakers, dear speakers, we couldn't access them because of some technical problems, sadly. We are running out of time, so I'm going to thank you again as audiences to spend your time with us for tonight, and also our speakers and our executive team here in Tehran University of Medical Sciences. And sadly, we do not have much more time for this session. So I invite all of you for our sessions holding tomorrow night. Thank you very much, and have a good day and night wherever you're living. Thank you very much. Ayla.